first, what we're going to be talking about, first what I'm going to be doing is I'm going to go through some basics of the Medicare program and Medicare prescription drug spending, and then I'm gonna raise some questions about, is Medicare paying the right amount or maybe too much for prescription drugs? There's some people who think that it is paying too much, that the prices that Medicare is paying for prescription drugs or subsidizing are too high, and I'll have a couple words to say about some recent efforts by Congress to try to reduce the prices that Medicare is paying for pharmaceuticals. The Bipartisan Budget Act of 2018, about which Luca will have even more to say, and the Inflation Reduction Act of 2022, which is the subject of Pragia's paper and about which she will have more to say. Then I'm going to just give an overview of some of the parameters of the of certain provisions of the Inflation Reduction Act that have to do with Medicare negotiating lower prices for prescription drugs, because those provisions or those parameters will come up later. And then I'm going to finish setting the table with some observations on the rhetoric that's surrounding the debate over prescription drugs and prescription drug pricing in Medicare, to try to cut through that rhetoric and clarify what's actually happening. Okay, so to get rolling, the Medicare program covers about 66 million people, or 19% of the U.S. population. It spends about $16,000 per enrollee, which may not sound like a lot, but across 66 million people, pretty soon you're talking about real money. The total spending is about $1 trillion or more, which is almost a quarter of national health expenditures in the United States. So this is real money we're talking about. It accounts for about a 4% share of GDP. So it's a significant chunk of U.S. GDP. But I want to draw your attention to the last bullet, most of all, because that is the Medicare program's prediction of the average annual growth rate in Medicare spending over this, the next several years. It'll be growing at a rate, they estimate, of 7.8% per year, which is faster than they project the U.S. economy will grow. And that's important because, as these charts from the Congressional Budget Office illustrate, the U.S. debt to GDP ratio is already at about 100%. That means the federal debt is about the size of the entire U.S. economy, and it is growing. It is growing. The federal deficit is growing as a share of the economy. It's growing faster than GDP, adding to the national debt, which is already in uncharted territory. If it keeps rising, we really don't know what's going to happen, but that it does pose a significant threat to the U.S. economy. And the main thing that is driving federal deficits and the growth in the federal debt is healthcare spending. It's healthcare spending at the federal level. If you look at these other graphs from the Congressional Budget Office, you'll see they show that federal outlays as a share of GDP and by category, and there's only two categories where federal outlays are growing as a share of GDP. One of them is net interest on the federal debt, and the reason that is growing is largely because of the other category that's growing as a share of GDP, which is major healthcare programs. And the reason major healthcare programs, so the reason that the main reason that federal deficits are growing as a share of GDP is healthcare spending, and the main reason that federal healthcare spending is growing as a share of GDP is the Medicare program. And there's always the predictable objection or retort that Medicare or spending generally is not the problem, that really the underlying problem when it comes to federal deficits is insufficient federal revenues. And certainly federal revenues are important. The deficit is the difference between outlays and revenues. However, I just wanted to call your attention to this last graph by the Congressional Budget Office, which illustrates that while federal revenues are currently as a share of GDP, are currently at their historic average, or at least over the past 50 years, their historic average, federal outlays are a couple percentage points higher than their average as a share of GDP over the past 50 years, which suggests that while both revenues and spending are contributing to to growing federal deficits, outlays or spending appears to be the larger of those two problems. Okay. Well, now, why are we focusing on prescription drug spending in the Medicare program? Well, it turns out this is a significant chunk of Medicare spending. The Medicare program estimates that Medicare in 2024 will spend about $146 billion on prescription drugs. Did we decide if that was just Part D or Part D net of rebates, but not Part B? Is that what we decided?
I think we decided it's an attempt at Part D net of rebates.
It's hard to figure out exactly sometimes how much Medicare is spending on prescription drugs, and sometimes, or that's arguably by design. But as a share of total Medicare outlays, it's about 13%, and and Medicare spending on prescription drugs is about a third of overall spending on prescription drugs in the United States. But again, I want to draw your attention to the growth projections in Medicare prescription drug spending. You will notice that for the next 3 years, this year and the next 2 years, the Medicare program predicts that growth in prescription drug spending by Medicare will it'll be growing. That category of spending will grow even faster than overall spending in the Medicare program. And this is significant for the laws that, when it comes to examining the laws that we're going to be examining in Congress's efforts to try to contain Medicare spending on prescription drugs. But for the moment, just keep in mind, it's growing at a pretty rapid clip. So the question arises, is Medicare paying too much? Is the reason that Medicare spends so much on prescription drugs and prescription drug spending in Medicare is growing so rapidly, is it because the prices that Medicare is paying are excessive? There's evidence that suggests that maybe that is the case. In 2018, the Trump Department of Health and Human Services put out a study of Medicare, the prices that Medicare pays for drugs that physicians administer to patients, what we call Part B drugs. And they estimated that the Medicare program pays about twice as much as payers in other countries pay for the same drugs. The Government Accountability Office a few years ago put together a study on the prices that the VA, the Veterans Health Administration, pays for drugs versus the prices that Medicare Part D pays for drugs. This is different from the Part B program I just mentioned. But the Part D part of Medicare pays, on average, more than double what the Veterans Health Administration pays for the same drugs. However you slice these data, if the VA were to pay the same prices as Medicare, the prices that it pays for those drugs would double. So how much should Medicare be paying for these drugs? Well, conceptually, that's a fairly straightforward or simple question. Because in the United States, we have a patent system that tries to embed in the price of new drugs or grants patent holders marketing exclusivity so that they can recoup the cost of researching and developing innovative new drugs, and embed in the prices of those new drugs the incentives necessary to undertake those investments. Given that we have a patent system, the right price, the socially optimal price for drugs is whatever encourages innovator drug companies to invest in innovations all the way up to the point where any more innovation would cost more than the benefits it would deliver. So whatever the price is that encourages innovators to keep investing in innovation until the total social cost of innovation or the total social cost of that last unit of innovation equals the total social value of that last unit of innovation. Simple, right? Because if the price is too low, so that's where you want the price to be, because if the price is too low, you're going to get too little innovation, and what's going to happen is a lot of people are going to suffer unnecessarily when if we had encouraged more innovation, there would be more drugs available on the market to treat and cure illnesses. But if the prices are too low, you're going to get a suboptimal level of innovation. People are going to be suffering and even dying prematurely because we got the prices too low. However, by the same token, it's also possible that we might be getting the prices too high. And if you get the prices too high, you create similar problems. society ends up devoting resources to drug innovation that would produce more human happiness someplace else. We will get additional drug innovation if the prices are too high, but a lot of that innovation will produce benefits, but it will produce benefits the cost of those innovations will exceed the benefits. So the benefits will not justify the cost, and there is some evidence that the Medicare program might be paying prices that are so high that we're getting this sort of innovation. The economists Pisanko, Drenov, and Garthwaite in 2016 looked at oncology drugs and concluded that Medicare Part D might have allowed firms to capture more value than their products created. That's another way of saying we might be over here in this zone where the prices are too high and we're getting excessive levels of innovation where the costs of that innovation exceed the benefits. They say while there are worries that if Medicare reduces the prices it pays for prescription drugs, we might reduce social welfare because we would get less innovation. Keep in mind that some existing regulations may provide incentives for innovation that are themselves not welfare maximizing because they are based on prices that exceed value. So we might be getting inefficiently high levels of innovation all the way up here. Okay. So Congress is aware of these concerns, and Congress has done a number of things to try to reduce the prices that Medicare pays for prescription drugs. One of Congress's efforts, and every time Congress does this, however, every piece of legislation Congress passes that has provisions that try to reduce Medicare drug prices is sort of a mixed bag. There are provisions in each of these bills that would tend to reduce the prices that Medicare pays, and other provisions that would tend to increase the prices. The Bipartisan Budget Act of 2018, about which Luca will be saying more, is one of those laws. It had some provisions that would tend to increase the prices that Medicare pays, such as increasing subsidies for drugs by reducing enrollees' out-of-pocket exposure, but other provisions that would reduce prices, including mandatory price reductions in what we call the coverage gap. And Luca will be saying more about what that coverage gap in Part D is. And he's going to be presenting on what I've got there in the last bullet, which is the provisions of the Bipartisan Budget Act that increase insurers' incentives to cover lower-cost biosimilars versus branded biologics. The Inflation Reduction Act of 2022, another mixed bag. Some provisions would tend to increase prices, such as capping enrollee out-of-pocket spending on insulin. Rather than run through the entire list, I'll skip right to the end. That's the provision that Pragya is going to be talking about, which is the provision that has been very much in the news of the Inflation Reduction Act that allows the Medicare bureaucracy to negotiate lower prices for prescription drugs, basically by telling drug makers that the Medicare, if they don't agree to lower prices, the Medicare program will not cover their products. The way those negotiations work is Medicare picked 10 drugs for which it will negotiate the prices with the manufacturers in August of last year. Those negotiations are ongoing right now, and by 2026, Medicare will be paying the new negotiated prices for those drugs. But before that, in 2025, Medicare will pick another 15 drugs to negotiate lower prices for those drugs, and then in 2026 another 15, and lather, rinse, repeat. We'll have this ongoing cycle where they'll keep picking more and more drugs and hopefully negotiating lower prices to the point where I think in 2029 there'll be 80, if my math is right, there'll be 80 drugs that Medicare should, if things go according to plan, be paying lower prices for. There are all sorts of restrictions, though, on Medicare's ability to do this, and Pragya will be talking about what those are. But the takeaway is that the Congressional Budget Office, and many of these are limitations on Medicare's ability to get the prices down. But the Congressional Budget Office projects that, on average, Medicare will be paying 50% less for these drugs that it purchased, for these drugs that it selected, than it would have been paying if the IRA had not passed. So now, to cut through some of the rhetoric that has been surrounding this debate over Medicare drug pricing, first, the Medicare program, a lot of people will say that Medicare has never before negotiated drug prices with the pharmaceutical companies. And I think that's inaccurate and really paints a misleading picture of what's been happening in the Medicare program. Because Medicare has been negotiating drug prices with drug makers for its entire 48-year history. It's just been conducting those negotiations at the level of lawmaking, at the level of statute, rather than at the level of the bureaucracy going out and making these and doing these negotiations with the drug companies. And what has been happening for the past 48 years is that Congress has been negotiating with the drug companies at the level of statute, and Congress, or at least the taxpayers, have been losing. Congress is not very good at these negotiations, which is why there are so many indications that the prices that Medicare pays for prescription drugs are so high, and that has led to so much frustration that Congress has finally farmed that job out to the Medicare bureaucracy, hoping that the Medicare bureaucracy will do a better job than Congress has. This is not unlike, since we're in the Hayek Auditorium at the Cato Institute, this is not unlike what Friedrich Hayek wrote about in The Road to Serfdom, where he described the process of central economic planning and how legislatures might set broad goals but then are incapable of pursuing those goals in a competent or efficient way because of the political constraints that they face and the information and incentive problems. And so then they then farm out those decisions to non-legislative bodies to make those decisions for the government. That's something like what is happening with Medicare drug pricing right now. Another claim that you'll hear in these debates is that the prices that Medicare is paying right now are market prices, and if Medicare reduces the prices that it pays to drug companies, then those will be price controls or below market prices. But I think it's pretty clear, and there was an article, I think, in the New England Journal of Medicine recently, was that where David and Richard's article, that very helpfully laid out that, look, these are not market prices that the Medicare program is paying. There are all sorts of things that the Medicare program does that inflates the prices that it pays above what we would see in a market. And if you're ever wondering about the effect that all of those provisions of the Medicare program have on drug prices, there's a very simple thought experiment that can clarify what the effect of those provisions is. Imagine the Medicare program took all $1 trillion that it was going to spend on behalf of beneficiaries, and instead of giving them using that money to give them health insurance, just gave enrollees the money and then let them buy their own health insurance and pay for their medications themselves. What would happen to drug prices in that scenario? I think most economists would agree. I'd be interested to hear what our panelists have to say about this question. But I think most economists would agree that drug prices would fall from their current levels, or at least drug prices for Medicare enrollees. That suggests that Medicare is paying above market prices for drugs. Next, the IRA, contrary to the claims of opponents of the IRA, doesn't impose price controls on prescription drugs or coerce drug manufacturers or tax manufacturers, because as the courts keep reminding those manufacturers, participation in the Medicare program is entirely voluntary for them. It is not coercive in any way. They can always back out of the Medicare program with some months' notice, but the fact that they can back out of the Medicare program, the participation is voluntary, means that the government is not coercing them. What's happening is they are getting above market prices for their products, and they want to keep getting above market prices for their products, and so they are complaining about any statutory or other changes that would reduce the subsidies that they are getting from government. Another important clarifying point is that you'll hear in this debate that reducing the prices that Medicare pays for prescription drugs will reduce research and development into new drugs, and any reduction in that sort of research and development and innovation is bad. And I think that that's a myth. It might be bad, but we don't know. And Pragya and her co-authors have something to say on this in their paper. But it is not per se bad if innovation falls, because we might be in that zone where we are getting too much innovation, and that's an important question that we have to explore. But it's important to reject the claim that any reduction in innovation is necessarily bad. And while it is historic what the Medicare program is doing, the Congress has allowed the program to negotiate lower drug prices directly with pharmaceutical manufacturers. I would hesitate to call this a success, because what it means that after almost 60 years, and it will be 60 years before any of the IRA negotiated prices will take effect, 60 years of Medicare's operation before any of those negotiated or lower prices take effect. What it means is that Congress has taken that long before it has done anything this serious about trying to get those prices down. I don't think that's an indication that the Medicare program is a good price negotiator. I think it indicates quite the opposite. And then finally, we have to keep in mind it might not work. Those price reductions have not taken effect yet. And you remember I mentioned, there we go. Remember I mentioned these growth projections for Medicare prescription drug spending in 2024 through 2026. That accelerated growth in Medicare prescription drug spending is in part a result of the Inflation Reduction Act and the provisions of the Inflation Reduction Act that will tend to increase Medicare spending on prescription drugs. The IRA, like many other healthcare bills that Congress has passed, takes sort of a dessert first, spinach later approach to Medicare spending. It front loads additional subsidies that have that will have the effect of increasing Medicare spending, in some cases increasing the prices that Medicare pays for prescription drugs, with the promise of fiscal restraint later on. The spinach will come later. We promise that in 2026 and the out years, we will really clamp down on unnecessary Medicare spending and excessive drug prices. It remains to be seen whether that is going to happen, because we have seen this before in the Affordable Care Act and in other laws that Congress has passed, where they have promised austerity, but not yet. So the Affordable Care Act created a lot of subsidies for the health industry, with the promise of reducing spending on Medicare Advantage plans. In reducing spending through something that they called an Independent Payment Advisory Board, or IPAB, and a change in the tax code that we call the Cato tax that would ultimately reduce spending on employer-sponsored insurance. But when Congress passes these sorts of spinach later proposals or spinach later provisions, what that does is it gives the industry time to go to work in the courts and go to work in lobbying the bureaucracy and go to work lobbying Congress to defang those provisions and make sure that they never have the hoped for effect of reducing Medicare spending. In the case of the Affordable Care Act cuts to Medicare Advantage, the health insurance industry, the beneficiary of Medicare Advantage spending, was able to defang those cuts by going to the Medicare program and persuading them to provide quality bonuses to mediocre health plans, mediocre Medicare Advantage health plans, which meant that those cuts had much less bite. The healthcare industry writ large went to Congress and got Congress to repeal both the Cadillac tax and the Independent Payment Advisory Board. So this sort of dessert first, spinach later approach to reducing healthcare spending often doesn't work. It remains to be seen whether it will work in this case. And lest you doubt the might of the healthcare industry and their influence on Capitol Hill, keep in mind these numbers from Open Secrets, which portray lobbying or expenditures on lobbying Congress by sector. And what they show is that the health sector of the economy spends almost 6 times as much lobbying Congress as the defense industry. The defense industry, which is almost 6 times as much. The pharmaceutical sector, or the pharmaceutical industry alone spends 2 to 3 times as much as the entire defense industry does lobbying Congress. This is a very effective lobby that is very used to getting what it wants from Capitol Hill, and it's so brazen that if you remember, if you watched the Super Bowl this year, and I did, I'm not a football fan, but I watched the Super Bowl. I watched the Super Bowl for the healthcare ads. This year, I watched the Super Bowl, and the healthcare industry did not disappoint. Pfizer, the pharmaceutical giant Pfizer, 5 months after the Medicare program announced that it would try to reduce the prices that it pays for Pfizer's drug Eliquis that it manufactures with Bristol Myers Squibb. Pfizer bought a 60-second ad during the Super Bowl, not a 30-second ad, a 60-second ad during the Super Bowl where it blared at audiences, at the television audience, the Queen song, "Don't Stop Me Now Because I'm Having a Good Time." Incidentally, this ad, estimates are that this ad set Pfizer back about $10 to $20 million. That is a drop in the bucket in terms of the money that Pfizer spends lobbying Congress, and that's an expenditure that did not appear. It would not appear in the numbers I showed you before. Interestingly, I found in researching this particular slide that Charles Pfizer and Charles Earhart, who were co-founders of Pfizer, were cousins, and interestingly, later on, also in-laws. So I'll leave you to unpack that. Well, I now cede the floor to Pragya so that she can talk to us.
If you want to see the rest of this discussion and learn more about the surprising flaws in Medicare's coverage of cheaper alternative drugs, including why it tends to lag behind employer plans and drive up costs, click here.